This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alera, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's titled Outcomes in Children Receiving Single-Fraction Gamma Knife Radiosurgery for Arteriovenous Malformation.
This is a topic that hits home for any pediatric neurosurgeon. Arteriovenous malformations, or AVMs, are the leading cause of non-traumatic intracranial hemorrhage in children. When we see these in the clinic, the stakes are incredibly high because of that lifetime risk of life-threatening hemorrhage or permanent neurologic deficit.
Exactly. And while we often think of microsurgical extirpation as the gold standard because of the immediate obliteration of the nidus, it's not always the best or even a feasible option for every child, especially when the AVM is in a surgically challenging or inoperable location. That's where stereotactic radiosurgery, or SRS, comes in.
Right, but the literature on pediatric SRS has been a bit heterogeneous. We've seen reported obliteration rates ranging from 64% to 77% at 5 years. There are also those persistent concerns about long-term risks, secondary malignancies, radiation necrosis, and the risk of hemorrhage during the latency period before the AVM actually obliterates.
That's what makes this institutional review so interesting. The authors, Montalvo and colleagues from UT Southwestern, reviewed a 2-decade-long experience from 2006 to 2023, treating pediatric AVMs with a very homogeneous single-fraction gamma knife approach. They felt their clinical experience was actually outperforming the multi-center registry data, and they wanted to see if the numbers backed that up.
Let's dive into the patient population. Who were they treating?
They had 89 patients with 101 AVMs. The average age was quite young, around 12.9 years, but the range went as low as 2.36 years up to 20.1. What stood out to me was the presentation. Over 70%, 70.8% to be exact, had a pre-SRS hemorrhage.
That reflects a high-risk cohort. And what about the AVM characteristics themselves?
Most were relatively small. 80.4% were under 3 centimeters, with an average volume of 2.85 cubic centimeters. However, these weren't easy cases. Eloquent areas were involved in 65.3% of the cases, and 56.4% had deep venous drainage. If we look at the Spetzler-Martin grades, the majority were grade 2 or 3.
It's worth noting for our residents listening that while most were grade 2 and 3, they did include some grade 4 AVMs, about 8.9% of the cohort. Now, let's talk about the technical side of the SRS. What was their protocol?
It was very standardized. They used stereotactic head frame placement under general anesthesia, which is standard for the younger pediatric population to ensure stability. They then used a combination of high-resolution MR angiogram and intra-arterial digital subtraction angiogram, or DSA, for targeting. They fused these images in gamma plan.
That fusion is key. Using the DSA for the hemodynamics and the MRA for the anatomy gives you the best chance of hitting the true nidus. What were their planning goals?
They aimed for a selectivity greater than 0.8 and coverage greater than 0.95. They prescribed a margin dose of 20 gray, but never less than 18 gray.
18 to 20 gray is a solid dose for a pediatric AVM. Now, the results are what we really need to focus on. Did they beat the registry averages?
They did. Their radiographic obliteration rates were quite impressive. At 3 years, they saw 55% obliteration. That jumped to 73.1% at 4 years and reached 83.0% at 5 years. But here is the kicker. In the patients with long-term follow-up, meaning those followed for more than 36 months, the obliteration rate for SRS alone was 90.6%.
90.6% is excellent. And they achieved an even higher overall obliteration rate if you include the salvage therapies, right?
Yes. They had 8 AVMs that failed to obliterate by the 3-year mark. These were retreated, 5 with repeat SRS, 2 with embolization, and 1 with resection. 7 of those 8 residual AVMs eventually obliterated, bringing the overall obliteration rate of the cohort to 97.6%.
That's a powerful message for the families, that even if the first round doesn't completely close the shunt, a multimodal approach starting with SRS can lead to near total success. But we have to talk about the price of that success. What did the safety profile look like?
This was perhaps the most striking part of the study. During the follow-up period, which had a median of 56 months but went up to 193 months for some, there were 0 secondary malignancies.
That's a huge relief for pediatricians and parents. The long-term concern of radiation-induced tumors is often the biggest hurdle when consenting for SRS.
Absolutely. And another major finding, no patients developed a post-SRS hemorrhage. Not a single one.
That's actually quite remarkable. We usually warn patients about the latency period, the 2 to 3 years it takes for the AVM to close, where the risk of hemorrhage persists. To have 0 hemorrhages in 101 AVMs is a very strong outcome.
Did they report any deaths?
No deaths post-SRS. However, it wasn't entirely without complications. They did report symptomatic radiation necrosis, or RN, in 7 patients. That's about 8.5%.
8.5% for symptomatic RN is well within the expected range, maybe even on the lower side for these doses. What about functional outcomes?
The paper notes that 39% of patients had neurologic deficits. However, we have to remember the context. 70% had a hemorrhage before they even got to the Gamma Knife suite. So many of these deficits likely preceded the treatment. They also found that 13% had residual seizures and 14.6% had persistent headaches.
This is a key point for our residents. When you are evaluating these patients, you have to distinguish between treatment-related toxicity and the sequelae of the original rupture. The study notes that the neurologic deficit assessments were based on neurology or neurosurgical evaluations in the record.
One thing I found interesting in their methodology was their follow-up workflow. They did an MRA every 6 months and a DSA at the 3-year mark, or sooner if the MRA suggested obliteration. Even after DSA confirmation, they kept following them with MRAs at 3, 5, and 10 years.
That's a rigorous protocol. It's the only way to catch late recurrences or late toxicities. So, Alara, if you are summarizing this for a medical student on a neurosurgery sub-I, what are the big takeaways?
First, single fraction SRS for pediatric AVMs is highly effective. With a 90.6% obliteration rate for SRS alone and nearly 98% with salvage, it's a very viable alternative to surgery for the right candidates. Second, the safety profile in this cohort was excellent. 0 secondary malignancies and 0 latency period hemorrhages. And third, the rate of symptomatic radiation necrosis was low at 8.5%.
It really validates the use of Gamma Knife in the pediatric population, especially when you have a standardized high-dose approach with integrated DSA MRA planning. It's a shift from some of the more pessimistic registry data we've seen in the past.
The authors actually mention that. They suggest that their results might be better because of the homogeneous radiosurgery approach at a single institution over 2 decades, rather than the heterogeneous data you get when you pool many different centers with different protocols.
It speaks to the importance of institutional expertise. Well, this has been a great deep dive into a very encouraging study for our field.
Agreed. It provides a lot of clarity for a patient population that is often very difficult to manage.
Thank you, Dr. Alara, and thank you all for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.
See you then.